start the recording. All right, welcome to CCRN Pulmonary 3. This is the conclusion of Pulmonary, and today we're really going to focus on just a few more issues in pulmonary management, and then the primary focus will be on understanding ventilation. So this will be a CCRN review for ventilation, but in the fall, keep your eyes open, probably early September, we'll be doing advanced ventilation class, and that will include clinical rounds, and advanced hemodynamics class, and that will also include clinical rounds. So keep your eyes wide for that, especially if you're interested in those two things. That will be really, really great. So thank you again, of course, for joining. And let's begin. So one of the things I wanted to do was to review again neuromuscular pulmonary disorders. Talked about it last week because remember last week we had neuro, and I wanted everyone to remember the difference between myasthenia gravis and Guillain-Barré. So last week when we talked about this, I reminded you that myasthenia gravis is descending paralysis and Guillain-Barré is ascending paralysis. So that's really, really important. Begins with MG, begins at the head and then descends into respiratory weakness. Guillain-Barré begins at the feet and then ascends into respiratory weakness. Myasthenia gravis is a lifetime commitment and a lifetime disorder, and Guillain-Barré is periodic. And typically it's periodic in association with a hyperstimulation and inflammatory response. So really, really important. Most important in differentiation is MG has ophthalmoplegia, meaning that you have lid droop, you have alterations in your eye movement, and with Guillain-Barré, you do not have that. So that's a really key sign for you to pay attention to in any questions or in any patients that you're seeing when you're determining, is this a neuromuscular pulmonary disorder? It typically tends to be quite obvious that it's neuromuscular, but the end result is diaphragmatic weakness and failure to be able to generate negative inspiratory force in order to breathe. Okay, so I just wanted to be sure that we felt really good about that. I reviewed those two after our wonderful neuro speaker, but I just wanted to review it again because there are frequently questions about those types of disorders. So now let's move to pleural effusions. And we're always going to remind ourselves when we talk about the pleura, we talk about two levels of pleura. It's very similar to the levels that you see in the brain and the levels that you see around the heart. The parietal pleura is actually the dura, and the internal layer of the pleura is visceral. And the separation between those two layers, of course, is called the pleural space. Now, normally you have lymphatic fluid in the pleural space at around 10 to 20 milliliters in a 10 to 20 millimeter space. So the width of the space is 10 to 20 millimeters, and the amount of fluid is 10 to 20 mLs. And what's really important for us to remember when we talk about pleural effusions is the rapidity of accumulation of fluid in the space. So with a cardiac tamponade, you're going to be bleeding into the pleural space. You rapidly accumulate in the space, and that, of course, compresses the heart. With a pleural, I'm talking about a pericardial effusion. I am so sorry. Wipe that out. Okay, so again, same thing though, when we're talking about a pleural effusion and how complex it is and how significantly it compacts the lungs, not the heart, how significantly it compacts the lungs depends on how rapidly that fluid accumulates. So if I have a bleed in the pleural space, a hemothorax, that will compress the lungs very rapidly and cause a mediastinal shift quite rapidly or deviation, whereas a slow increase in fluid over time typically will cause some reduction in functional lung recruitment, but not necessarily an acute alteration in ventilatory capability and an acute alteration in the process of the mediastinum. So if we take a look here, here's a nice little pleural effusion. This is an artist rendition, and then a chest x-ray. The reason that you know that this is outside of the lung is you have a very firm evaluation of the end of the lung. Whereas when you have effusions in the lung itself, they are more diffuse, and you actually would see the normal level of the lung like you see it right here, right? So this actually indicates to us that this is a pleural effusion. Now it's pretty significant, right? It's taken up compartment of about 2/3 of the lung, compressing the lung. That means now this tiny space is relatively non-compliant. And what we've done actually with this pleural effusion is tamponade the lung. That means it's harder for me to breathe. If I'm intubated and ventilated, I'm going to be breathing with a very high pressure because I have a very low compliance of the lung. So again, thinking about that pleural effusion, whether it's rapid or slow accumulation is going to determine how profoundly the patient presents, how rapidly they decompensate, and what you're going to do for that patient. So pleural fluid is always overturning. It's lymphatic fluid, right? And the rate of fluid formation is about 0.02 mLs per kg per hour, and we clear exactly the same amount. Now, I love talking about this because I think it's so incredibly important for us to appreciate that these concepts are contiguous across all of our organs. When we talk about cerebral spinal fluid and the rate of fluid formation, the rate of fluid clearance, they're always equal, or they should be equal. In normal physiology, they're equal. Pleural fluid formation and pleural fluid clearance are supposed to be equal. Now, if I'm overproducing or underclearing, I'm going to have a pleural effusion. Right? Overproducing, underclearing. I'm going to overproduce, of course, when I have inflammation, when I have a high hydrostatic pressure in my pulmonary vessels, such as with cardiac failure, when I have a high accumulation of blood urea nitrogen, which freely moves across your capillary wall and accumulates in space and is very hyperosmotic, so it pulls fluid with it. So I can build the fluid up, or I can have a problem with my clearance. Now, the problem in clearance is really related to the pressure in the lymphatic vessels, which are also reflective of the pressure in the pulmonary veins. So whenever your capillary pressures, so that would be, we would assume that capillary pressures go up when we see LV failure. We're going to measure your capillary pressures with a PA catheter, and that's called the pulmonary capillary wedge pressure. Whenever capillary pressures are up, that's going to promote more fluid extravasation, and you can see that in the pleura. And also whenever there's a change in your capillary permeability. Now remember, when we have high volume load in our vessels, the hydrostatic pressure is going to force fluid across the pulmonary, across the capillary wall. Whenever you have inflammatory mediation, that's going to cause disruption in the barrier of the capillary wall, and fluid is going to move out into that space. And then, very importantly, obstruction to the lymph vessels. Now, the primary obstruction that you would be asked about would be related to malignancy. So if I have a malignant tumor, a large tumor that is growing, putting pressure on the lymph vessels and the collection vessels, I will actually see a significant increase in fluid buildup. And of course, that then crosses across the lymph vessels and accumulates in the pleural space. Okay, so basic signs and symptoms really aren't that differentiated. Patient is short of breath. He typically has a dry cough. Breath sounds are decreased. And when you percuss, remember, you've got a patient that's got some alteration in lung compliance. They may have dysynchronous expansion of the lung. If I put my hands on the chest, pinch some skin right over the sternum. I'm going to see one hand moves more than the other because one lung is more expanded than the other. I now have to say, okay, I have dysynchronous expansion of the lung. I now need to evaluate, is this a pneumothorax or is it a pleural effusion or a hemothorax, right? And in critical care, it's usually we're trying to evaluate a hemothorax, but pleural effusion, hemothorax. What we're going to do is we're going to percuss over the area that isn't moving well. When we percuss over the area that isn't moving well, remember when you are percussing over an area, the sound will be much greater if it is carried through air. So if I have a pneumothorax, I'm going to have a tympanic sound. If I have a pleural effusion, when I percuss over that area, the sound is going to be dull because fluid is going to absorb the sound. So that's always a really important thing to remember. So let's see if I can make the sound. This kind of has fluid in it. So, okay, that's tympanic. That's dull. Okay. Tympanic versus dull. So the first thing is I look at the patient, they are having difficulty breathing. They have decreased breath sounds. I see that they're working hard to breathe. They're using their accessory muscles. I put my hands on the chest. I pinch some skin over the sternum. I watch if the hands move synchronously. So let me see if I can make sure you see that. The hands move synchronously or dysynchronously. When we're communicating with our patient. And if the hands are moving dysynchronously on the side where there is dysynchronous movement, I am actually going to percuss. And I'm going to percuss there and listen to whether the sound is tympanic or dull. So that's very, very important, tympanic or dull, in order to evaluate, do I have a presence of free air or do I have the presence of free fluid? Free fluid absorbs sound, that's why it's dull. Free air enhances sound, and that's why it's tympanic. Now, I want to remind you also that typically when we ask patients to tell us about chest discomfort, not chest pain, chest discomfort, you should always use these particular words. And that they're not going to test you on this on the exam, but for our clinical practice, this is really important. The words that we say are, show me where the discomfort is. Don't say point, because patients and nurses and doctors do what you've said, which is point, okay? The difference between basically angina-related or acute coronary syndrome-related chest discomfort and pleural discomfort or pericarditis is that individuals, when you say show me, typically for acute coronary syndrome, they're going to use the palm of their hand or the fist. That's called the positive Levine sign. But with pleural pain, pericardial discomfort, they can isolate it, and they usually use 1 to 2 fingers. They don't use their fist. They don't use their whole hand. So that's a really important concept in our clinical evaluation of patients that can guide us somewhat. Now, that's usually mild to sharp. As we know, it's worse typically when patients take a breath. And when we look at the chest X-ray, fluid always accumulates in the dependent area. So if I have a patient who's a walk-in patient to the ED and they're sitting upright or they're standing upright, I'm going to see the majority of that fluid at the base of the lung. But if I'm talking about a person who is laying in bed, that fluid is going to be across the posterior surface, okay? So always remind yourself that fluid is typically in the area that is the most dependent when we take a look at our chest X-ray. Okay, so of course, looking at this chest X-ray, we can see, first and foremost, I'm looking here, I can see that this is outside of the lung. There's a definite difference between the inside of the lung, here's my lung lining, and here's all that fluid, okay? So most likely, first thing that we'll consider is we'll just do a tap. And we can do a tap on patients to relieve accumulation. The most common patient who will have a continuous accumulation of fluid and pleural effusion is going to be patients with cancer who have obstruction of lymphatic outflow, and in chronic renal failure patients whose urea accumulates in the space and pulls fluid. So quite commonly, when we see those patients, we have to tap them. So we can do a basic tap, a therapeutic tap. We can also do a diagnostic tap, and we're just tapping. But in a critical care unit, the probability is that you're going to need to place a chest tube, right? And the decision that we make about chest tube actually depends on how significantly altered the lung function is. So again, my patient, if they're intubated, I'm seeing that their peak inspiratory pressure is going up, their P plateau is going up, and they are not oxygenating appropriately. I'm going to want to improve that. So it is somewhat dependent on the size of the effusion, but very importantly, it's on the symptomatic effects and how significantly affects the patient's capability to breathe. Okay, we're going to move from that to pulmonary embolism. I love this visual. I wish I had made it. I didn't. Here's your PE right here. And you can see it's sort of in the distal pulmonary vessels, but it's occluding all the blood flow to all those distal surfaces. So pulmonary embolism is like an acute coronary syndrome. That's a STEMI. It's occlusion to blood flow. If I don't flow blood through the lung, I cannot oxygenate and I cannot remove CO2. I want to remind you again that oxygen moves about 20 times more slowly than carbon dioxide. So frequently, accumulation of CO2 could be a little bit later sign. That what we typically see first is loss of oxygenation, because oxygen is a much larger molecule. It's not in as high a prevalence, especially, of course, if you're breathing room air or you're breathing 30% or 40% FiO2. Very important. Okay. Still on neuromuscular. Huh. Okay, well, we are not on neuromuscular. We are on something else. Okay. So I've just gotten a chat. So excuse me for one moment while I see what I can do. If I can download this, that may make it easier. Okay. Yep. All right. Let's see. All right. So I'm going to thank you very much, guys, for chatting. And I know you also have the handout, so that's good. But let's see, does this make a difference? So give me a chat. Can you see pulmonary embolism? Give me a quick chat, guys, because I'm relying on you because I can't see what you see. I can only see what I see. So you got to give me either a thumbs up, making your video open, or a chat. Good. Just effusions. Okay, well, don't know what to do about that, my friends, because I am showing the actual slide and I'm doing it in PowerPoint. So I'm not certain, but I'll tell you what, I'm going to stop sharing and I'm going to start sharing again. Can only see which one do I want to do. I'll do this one. And are you now able to see pulmonary embolism? Give me a chat. Perfect. Okay. And then Derek, just keep me apprised if you're not seeing as I move forward. This is the beauty of technology and the reason we need to be careful about AI, because it sometimes doesn't work very well. Okay. So pulmonary embolism, a fantastic thing for us to talk about because it's pretty common for us to see. And there's always a discussion about Virchow's triad. So there'll be a reference to Virchow's triad. And what you just want to remember that this is the common predictors of patients who are at risk for formation of both DVT and a DVT that embolizes into the pulmonary circulation. So Virchow's triad is actually about patients at risk for making clots, patients at risk for making clots. Okay. And so these are the three things. If your patient is immobile or they have occlusion to blood flow, like they have heart failure, so they have venous stasis of blood. So they're immobile or they have venous stasis of blood. That means that the blood is sitting and it's going to be much more likely to clot. That's number one. Number two is hypercoagulability. Typically, hypercoagulability occurs because there's been some exposure of either the protein surface of the endothelium to air or to fluid, and that actually stimulates clotting. Now, that clotting can be occurring in small vessels, not something that you're going to see at larger vessels. Typically, what you see with hypercoagulation is the patient is consuming their platelets. So their platelets are starting to drop, but their PTT and INR are starting to increase. Okay, so you're seeing less evidence of clotting, but consumption of platelets, and that's usually down in the microvasculature. And that typically occurs because of some type of injury, either inflammatory injury or vascular injury. And of course, if I know that you've had vascular injury, something simple, like the placement of a central line, like the placement of a vas cath, where we know we've had injury to the vessel wall. These three things, if they are in position together. So I've got a patient who is intubated in the bed, who I've catheterized for CRT, whose platelets are going down and PTT and INR are increasing. This patient is at a profoundly significant risk for DVT and pulmonary embolism. Okay. Now remember, pulmonary embolism arises from a clot that formed in the venous circulation, in the right atria, the right ventricle, and has moved up into the pulmonary vessel. So most commonly, it's a venous thrombus that has been cut loose or has come loose and mobilizes via blood flow into the right atria, the right ventricle, and into the pulmonary artery. So the effects that you see are going to be all about the right heart, all about the right heart, all about the venous circulation, right? We're not talking about a clot that was formed in the left atria, the left ventricle, which then gets mobilized into the aortic arch and up into the carotid arteries, right? That's an arterial thrombus or embolism. We're talking about a venous embolism. So it stops in the pulmonary vault because the clot will not move through the capillaries, okay? So everything we're going to talk about in relationship to pulmonary embolism is really going to be about the right heart and the venous circulation. Okay, so here's something very beautiful that we're taking a look at here. And you may not be a reader. Hi, guys. Unless you have a question for me, if you wouldn't mind muting yourself, that would be really, really, really great. Thank you. Okay, so other things that can happen that give an embolic effect, So not DVT, but an embolic effect, meaning right heart dysfunction, failure of oxygenation, CO2 removal, okay, is an air embolus. Okay, now, how much air would you have to put into someone's vein for them to have an air embolus? Probably close to 10 cc's. Not a tiny little cc, not the air that's in your heparin dedicated IV on your CRT, because that's less than a cc of air, and that air is going to be absorbed by your deaeration chamber. We're talking about a significant amount of air. Small little air bubbles that are in your IV tubing because you thought you flushed it, but you didn't. And that little air bubble is probably, 0.25 cc's. That's not going to cause your patient a significant problem. An air embolus is significant. And for most of us, there is no possibility for us to give a patient an air embolus unless we are working with somebody who just got out of nursing school, never hooked up an IV before, did not flush their line, attaches it, and then forces the air in under pressure. that would cause an air embolus. So we should be very careful not to assume that our new nurses know better. We're going to teach them that, right? Amniotic fluid. So amniotic fluid actually is not that uncommon to see in somebody who is immediately postpartum. There's inoculation of the amniotic fluid into the venous circulation, and that amniotic fluid does not actually transport gas, and it can significantly alter our gas exchange. It's not a true occlusion. It is a gas disruptor. Fat particles, and this patient has a fat particle. That's what you're seeing right here. This dark circle, that could have been another type of embolus, but this is a fat particle. Very common to see after traumatic injury of the long bones. And so we're always going to be aware of that. Particulates from substance IV drug abuse. So sometimes particulate matter, they didn't melt their heroin effectively, or there's particulates in the heroin, then they inject it, and they're injecting into the vein, and that particulate is then delivered into the pulmonary circulation. Okay. And of course, whenever you have a venous catheter, that you go in the room and you say, let me flush this catheter aggressively, right? Like with a venous catheter, with a central line, with a vas cath, right? If you never push first, you always withdraw. If you have resistance to withdrawal, do not push, right? You can use cath flow or some clot dissolution methodology, but you're not going to push, because even the smallest clot on the tip of a catheter can then be embolized into the pulmonary circulation. Now, sometimes it embolizes into the distal pulmonary circulation and you don't really see much effect. It actually has to be a fairly large embolic event to see a significant, profound effect that causes the decrease in gas exchange and the workload on the pulmonary vault. Okay, so signs and symptoms, pretty straightforward. It's sort of like everything. It's like patient's got a dry cough. He's got chest discomfort. He also may have, this is usually a sudden onset. So it's not like, oh, I was having trouble getting to my mailbox, and then today I had trouble going down the stairs and I'm getting increasingly short of breath. It is typically a sudden onset of shortness of breath, and significant sudden onset of shortness of breath, okay? And you typically will see, because of that occlusion, the pressure in the pulmonary vessels goes up, and now you start to transudate, basically plasma transudate from the vessel because of the high pressure behind the embolus. That high pressure pushes that transudate into the alveolus, and you will see hemoptysis and frothy cough. But the difference between pulmonary edema frothy cough, which is hydrostatic pressure pushing into the alveolus, is that this is not just basic fluid, it actually has components of blood in it. So that's really important for us to appreciate. Typically, what you're going to see on the blood gas early on, because the patient is going to be breathing rapidly, the biggest sign is that they have hypoxemic respiratory failure. And early on, they may have a very low PaCO2. Okay, early on, they may have a low PaCO2. As time goes by, that's not going to be true. Okay, they may also have a positive Holman sign, which is the calf pain that is associated with DVT. May not have that because the DVT may have embolized, but the Holman sign is calf pain associated with deep venous thrombus. They may also have a very loud S2. That's the second heart sound. That second heart sound is indicating to us that it's the end of systole. So remember, it's the closure of the aortic and pulmonic valve, and you may hear that sound very loudly because of this occlusion in the pulmonary vault. Something else that you might see, it's pretty unusual, even though everybody talks about it, and you should be aware of it. If you're looking at an EKG and you're trying to diagnose a pulmonary embolism on an exam, on exams, we ask you questions that may or may not be the most representative of your clinical environment. Less than 10% of patients with pulmonary embolism will present with a very particular pattern. That is an S wave. S means it follows the R. So you find the R first, you have a downward wave after the R in lead one. That's abnormal. And this is called S1, meaning an S wave in lead one. You have a small Q wave. That's the wave that goes downward before your upright wave, the R. So small Q in 3. So that's S1, lead 1, small Q in 3, Q3, and an inverted T wave in lead 3. So looking at leads 1 and leads 3, you're looking for an S wave in lead 1, a Q wave in lead 3, plus an inverted T wave in lead 3. And those are limb leads 1 and 3. Okay, less than 10% of patients are going to present with this. You don't ever diagnose a pulmonary embolism from an EKG. It might tell you you need to look further, but you're not diagnosing a PE from an EKG. If you ever see these signs, you're going to ask for an echocardiogram. And that's how you're going to diagnose this best at the bedside. Okay. All right. So again, large PE symptoms preceded by small emboli, but large symptoms, you have central chest pain. The neck veins are distended because you've got obstruction in the pulmonary vault. So you're not flowing blood through the pulmonary vessels. You have RV stasis, you have RA stasis, and you have venous stasis. So we're going to call that acute right heart failure. The RV is full of volume and is distended. The RA is full of volume and is distended. Your veins are full of volume and they're distended. Now, if I see these things, central chest pain, distended neck veins, I do an echo and I see that I have a large RV, I'm now going to rule out RV infarct versus pulmonary embolism. And I'm most likely going to say, did this patient have a risk factor for PE? Yeah, well, they came from a nursing home and they've been immobile for, a month. And their calf is very tender. That's the Holman side. Okay, I'm pretty sure this is a PE. I'm going to proceed down the PE path. Not going to matter too much because I'm probably going to send that patient to the cath lab. If it's a large pulmonary embolism, they're going to go to the cath lab where intervention is going to be applied. Now, I want to remind you about PEA because I think we have a lot of problems really understanding PEA. PEA means the problem isn't electrical, it's mechanical. And the mechanics of the problem are obstruction. The number one obstruction that causes a pulseless electrical activity present. So I have an EKG, not VTAC, not VFib, that's not PEA. PEA means I have a normal or relatively normal electrical rhythm. I probably am tachycardic, but I have a normal electrical rhythm, but I do not have a mechanical response. Okay, yes, you're going to do CPR. It probably isn't going to help much. That's why PEA arrests typically do not survive. They have obstruction to outflow. And the most common obstruction to outflow is a pulmonary embolism. So this has to be a massive PE. So you may have started as a small PE and now it's submassive because all the blood that goes by it is actually depositing platelets and red cells to a very sticky weed that's there. So you started with a small and now it got bigger. Now it's submassive and then it becomes massive, right? Once you have a massive PE, there's not much we can do. What we try to do is treat patients with submassive PE. Those are the ones that we're going to do ECOS catheter, which is a pulmonary artery catheter with ultrasonic delivery of a fibrinolysis or a thrombectomy. But once it's massive, you don't really have long for this world. Because a massive PE means that you have full occlusion of blood flow through the pulmonary vasculature. So we're really going to listen to what our patients are saying. We're going to evaluate them. We're going to watch at those progressive signs. And the progressive signs are signs of acute right heart failure. So we can get an EKG. You may have a right axis deviation, probably will. You're going to, if you're lucky, you're going to have an S1, Q3, T3, probably not, but you are probably going to have a right axis deviation. And you're going to pay attention to these signs and the progression of these signs in order to make some good decisions. So let's take a look at this EKG. This is a 12-lead EKG of one of our, was this one of our patients? I'm not sure, maybe not. Okay, so here is your S wave in 1. Sorry, I thought I had a circle on that. S wave in 1, Q wave in 3, and inverted T wave in 3. S1, Q3, T3. S wave in lead 1, Q wave in lead 3, inverted T wave in lead 3. S1, Q3, T3. And that's kind of the mnemonic that people use when they're taking a look at this. Now, in this case, your patient does not have a right axis deviation. He has a normal axis. But a lot of times you'll see a right axis deviation. You might even see a right bundle branch block. Do you diagnose PE from an EKG? No. Do you get some clues that you need to look further from an EKG? If you're lucky, but you don't diagnose it from an EKG. Okay, so we're going to do a chest x-ray, we're going to do a CT, we're going to do an MRI, we're going to do an echo. And by the way, the echo is going to be the soonest and the easiest. But we're not really talking about POCUS, which POCUS doesn't really give you a good RV window. So you need an echo window that is going to really highlight the RV. Now I can do a POCUS, and if I have really, really significant RV dilation, which is the first thing that happens, I may be able to see it with POCUS, and especially if I've got somebody who's really skilled. But typically we'd like to do a full multi-view echocardiogram if possible, okay? We'll also consider doing a venous ultrasound of the lower extremities, looking for the presence of DVT, which will then lead us to the perspective that you've had a pulmonary embolism. But what we're actually looking for, no matter what we're looking for is a dilation of the RV and global and regional hypokinesis, because as the RV distends, we're stretching the muscle out and it's going to be less functional. So we're going to see that RV dilate. We're going to see that the septal wall is actually going to shift over into the left ventricle. That's called the paradoxical septal motion. The septal wall shifts over to the LV. What that means is that on echocardiogram or POCUS, your LV is going to look relatively empty. Why? Why does your LV look relatively empty when you have a big PE? Okay, that's the start. Why is your LV relatively empty? You dropped your blood pressure. You're unstable. I'm adding a vasopressor, which isn't treating your problem at all. Can I give you fluid and make that LV fill up? No, because I have what? An occlusion to the blood flow. It's a dam in your pulmonary vault. Blood stays in the RV, the RA, and the veins and doesn't get to the LV. So the LV is relatively empty. Now the muscle may be working in a hyperdynamic framework because I have catecholamines that have been released and I have a functional LV. It's the RV that's dilated. Okay, as the RV dilates, it may pull the valve leaflets apart in the tricuspid valve, and I may have tricuspid regurgitation, doesn't always. Okay, but the area of the RV, the surface area of the RV has increased. Okay, the dilation means that I have a lot of volume in the RV. Okay. Now, what I'm going to tell you is that very early on, you have an acute compensatory increase in your respiratory rate and respiratory effort. And what you're going to see is that you're going to have lower oxygen because you've reduced functional surface area for gas exchange. But because CO2 moves 20 times faster than O2, you're going to clear the CO2 because you're hyperventilating. That's only early on. That's not going to be true later. Okay, only early on in diagnosis, low oxygen, low CO2, rapid respiratory rate. And when I look at your labs, I'm typically going to see byproducts of clot lysis. Byproducts of clot lysis are D-dimers and fibrin splits. If I'm making a lot of clots, I'm going to be lysing the clots as well. It's just that I'm not in balance. I'm making more clot than I can lyse, but my D-dimers and FSPs go up. Sometimes people get confused about that. They're like, well, the patient's hypercoagulopathic. Why do I see byproducts of clot lysis? Because you still have an intact function. You're making 1,000 clots and you're lysing 500. So the D-dimers and FSPs go up because you're lysing some clots or some portion of your clots. So that's really important. I don't think we make decisions anymore based on D-dimer and FSP, but there may be a question on that on your exam because it's still kind of something that people talk about. Most important, echo window, venous ultrasound. And we might, if it's a submassive, and if your pulmonary embolism response team says this is a PE, it's submassive, that patient's going to the cath lab where we're going to do a pulmonary angiogram, which means a PA catheter is going to be placed. We're going to inject dye into the pulmonary vessels. So when you get a patient back and they say he had a right heart catheter, what that means is we put a PA catheter in, right? A left heart catheter means you put a catheter in the aorta and inject it into the root of the aorta to visualize the coronary arteries. A right heart catheter allows me to visualize the pulmonary artery. That's the difference between left heart cath and right heart cath. So very, very important when we're understanding that and we're communicating. People go, he had a right heart cath. Okay, yeah, big deal. He had a PA catheter. Okay, good. PA catheter went in, it came out. Normally they don't come upstairs with their PA catheters, but if they had a submassive PE, pulmonary catheter is placed, dye is injected, we see the PE, we try to put the PA catheter into the main vessel where the PE is, and now we're going to deliver ultrasonically, we're going to deliver fibrinolysis. Okay? Now, that's the ECOS catheter. So there's many other catheters that are used and many other methodologies. No one's going to ask you about a specific methodology. They're just going to ask about. Oh, good job. Thank you. Can't fill. RV is larger, but what? So this is the little answer to the question. Thank you, Derek. But what I want you to remember, it's not whether the RV is larger. It's that you're obstructing blood flow. When you obstruct blood flow, you are going to go into PEA. You're going to have a normal electrical rhythm, but no mechanical response because the LV didn't fill. Okay, now obstruction can occur at the aorta as well, but we're talking about pulmonary embolism is the #1 culprit in pulseless electrical activity, which is why, sorry, this is the hospital, so let me just answer really quickly because it might be an emergency. So excuse me for one moment. Hi, this is Barbara. Take a few breaths, class. I'll be right back. Thank you so much for your patience. I'm just got to answer a question about a patient in the emergency room. Okay. Well, we're going to change this because this is just crazy. All right, my friends. So coming back to pulmonary embolism, thank you for your patience. I love that. I did need to address something that's going on with the patient. So that's what I'm really here for. And I'm just so happy to teach CCRN review as well. All right, so let's just take a quick look. Okay, so some things that there may be some reference to would be McConnell's sign. McConnell's sign is something that we always look at on echocardiogram. And when we have an acute pulmonary embolism, remember what we're seeing that we have a large RV. The RV is dysfunctional, but typically what we also see here is something that we don't normally see, and that's really the vascularization, because we've got stasis of volume in the pulmonary vessel. You see this vascularization, and that's what this is right here. This is McConnell's sign. That actually is a highlight of vascularization, and you can see all along here, you're kind of seeing these vascular highlights, but this is really significant with McConnell's sign. So remember, we're looking at RV dysfunction, a large RV. We're seeing the septal wall move over into the LV, and we also look for McConnell's sign. So that's going to be also an important concept. There may be a reference. No one's going to ask you to look at an X-ray and diagnose McConnell's sign, but in a question, it may say patient has a positive McConnell's sign. Positive McConnell's sign is directly linked to pulmonary embolism. Now, they really like all those signs, Chavostek, Trousseau, all these different signs they like to talk about, and it's kind of important for us to appreciate and understand. So in general, no matter where it is you work, you're going to activate a pulmonary embolism response team call. It might be that you're going to activate cardiology, or you're going to activate a PERT team call. That PERT call, what they're going to actually do is they're going to take a look at the patient, look at how large that RV is, and look at that septum, which is deviated over into the left side, making the left ventricle relatively empty and the chamber much smaller. So immediately, of course, we're going to provide respiratory support. We're going to do that. We're going to be ordered to do that. We're going to treat pain and agitation. We're then also going to give anticoagulants. And remember, we're going to start with IV heparin. Now, that IV heparin is not going to dissolve the clot that's already there. Only fibrinolysis is going to do that. Heparin doesn't dissolve a standing clot. It just protects us from further clotting. So really important to remember that giving heparin is about protecting you from further clotting, but it is not going to dissolve that clot. Patient may need to go to the cath lab, have an embolectomy, have fibrinolysis, direct fibrinolysis, and long-term, depending on what their situation is this a heart failure situation? Is it atrial fibrillation? Are you always bedbound? Long-term, we'll think about putting in an IVC and long-term anticoagulation, because we've got to protect you from having this occur again. Yes. Pardon me? Here at Grady, your provider. At Mass General, the nurse or the provider. I mean, nurses are providers too. So I like to say it this way. Your prescriber. So that would be your APP or your physician. At Mass General, all providers, so a pharmacist, a nurse, a respiratory therapist, all can activate the PERT team. But here it's the prescriber who activates it. Okay? And we do have a PERT team here. I don't know if you realize that. We do have a PERT team and a PERT call. All right. So very kind of connected to this, and certainly a beautiful segue, is into pulmonary hypertension. So if you just take a look at this very nice artist rendition, you're seeing that your veno vessels and your arterial vessels are all open wide, really beautiful. RV empties easily into your veins, which are open wide, and the pulmonary arteries return the blood effectively to the left heart. They're all open wide. With pulmonary hypertension, the first thing that is affected in pulmonary hypertension is the pulmonary arterial structure. So the pulmonary arteries are constricted, narrowed, which means because your pulmonary veins go into capillaries that give rise to arterialized capillaries and pulmonary arteries. And as the arteries are constricted, your veins are going to dilate. And you're going to have pulmonary venostasis. And if you have pulmonary venostasis, you're going to have RV stasis. And if you have RV stasis, you're going to have RA stasis. And then you're going to have systemic venostasis. So this is another more subtle way of obstructing blood flow to the LV. It's not a big clot, it's constricted vessels. And in this venue and on your exam, although I'm going to remind you about your clinical practice, in this venue and in your exam, we're talking about individuals who have chronic pulmonary hypertension, which means they have time for their RV muscle to increase, for their RV to hypertrophy. That takes time. So you don't see RV hypertrophy immediately after a pulmonary embolism. But patients that you see with pulmonary hypertension typically have a chronic disorder and they have RV hypertrophy. So they will also have a right axis deviation and signs of RV hypertrophy on EKG. And again, that's not how you're going to diagnose them. You actually have to look at their pulmonary pressures. So really important to remember that pulmonary hypertension means pulmonary arterial pressure is up. And second to that pulmonary arterial pressure going up, that increases the work of the right heart. So they have a secondary right ventricular failure. Pulmonary hypertension is a pulmonary artery pressure that is greater mean pulmonary pressure, greater than 25 at rest or greater than 30 with exercise. So normal pulmonary mean arterial pressure is like 12 to 18. So you're almost twice as high with your mean pressure. Okay. And there's 5 groups in the chronic classification by the WHO. Okay. So pulmonary arterial hypertension, idiopathic secondary conditions, because of left heart failure, because of pulmonary failure, because of embolic or coagulopathic causes, so like with PE, causing pulmonary hypertension, right? And a grab bag means lots of other things, sarcoidosis, other inflammatory conditions. So basically 5 groups. No one's going to ask you this question. What you want to remember is this is your index of suspicion. You've got LV failure, you might have pulmonary hypertension. You've got a pulmonary embolism, you will have pulmonary hypertension. You may have pulmonary hypertension from an autoimmune disorder. You could have pulmonary hypertension because you have COPD, because you have ongoing severe asthma or bronchitis. So just understanding this is really telling you about patients at risk for pulmonary hypertension. Now I'm going to step outside of the CCRN exam and I'm going to tell you the #1 cause for nosocomial pulmonary hypertension is a PEEP greater than 10. Okay, so in the hospital, we see secondary pulmonary hypertension related to the methodology of ventilation. Because as I put more pressure into the alveoli will compress the pulmonary vessels. So that's not part of the WHO group and it won't be part of your exam, but it is part of your practice. Okay, so for classes, class 1, you've been diagnosed, but you don't have symptoms with normal activity. You only have symptoms with excessive activity. Class 2, you have symptoms at rest, and you have fatigue, shortness of breath, and chest pain with normal activity. So you've got symptoms at rest, those symptoms have some shortness of breath, but it gets much worse when you have activity. Class 3, you're comfortable at rest, but you always have symptoms when you're active. And class 4, you always have symptoms. And this is, of course, class 4, just like class 4 heart failure. Class 4 is the worst class. Okay. And again, no one's going to ask you to define those classes. Some drugs can actually cause pulmonary hypertension. The ones that are the most important to us would be things like cocaine, other amphetamines, and methamphetamines. Those are the ones that we see the most. This is what we're most concerned about. We rarely see people taking rapeseed oil to a toxic level, although they may do that because their psychic told them that would help them get pregnant. I don't know why anybody takes rapeseed oil. I don't really know what it does. Don't know much about it. But what I want you to remember is where we are most likely to see pulmonary hypertension is in patients who are methamphetamine, crack cocaine, Very important for us to consider that. It's pretty likely that you're going to see that with patients who utilize those agents. Okay, so primary diagnoses, going to do a chest x-ray. And here, remember, this is your McConnell sign. That's the enlargement of the central pulmonary arteries. On EKG, you may have what we call a peaked attented P wave that will typically be in lead 2 and V1. The tented P wave is known as P pulmonary, meaning a big P wave on the pulmonary side of the heart, P pulmonary, a sharply spiked P wave in lead 2 and V1. You also may have RV hypertrophy, which means you're going to have a very tall R wave in leads that you don't normally. That would be V1, V2, and V3. And a right axis deviation. Again, no one's going to ask you to diagnose an EKG. They're not going to say, look at this EKG and tell me what you think. And we do not diagnose pulmonary hypertension from an EKG. But if on the EKG, we see a really big R wave, but narrow time, normal width, but really tall in V1, V2, V3, along with sharply spiked looking tented P waves in lead 2 and V1, I'm going to say, hey, I might need to look at this patient for pulmonary hypertension. Okay. And again, the definition and the best way for us to do this is with an echocardiogram. The echocardiogram allows us to evaluate and non-invasively or minimally invasively actually evaluate your pulmonary pressures. And most particularly, we're going to look at PAS. Pulmonary systolic pressure is a representation of RV ejection into the pulmonary vault. As that pressure goes up, that tells us two things. We have resistance in the pulmonary vault, and the RV is working really, really hard to eject volume up there. So we're going to use the echocardiogram here a little bit differently than we did before, because here we're looking at PAS. That's our primary goal. We're also going to look at RV dilation, et cetera, just like we did before. But our primary goal here is to identify your pulmonary arterial systolic pressure. Okay. So now let's take a look at this EKG. Okay. So take a look, lead 2, look at that P wave, right? You're in lead 2, look at your P wave here in lead 2, look at your P wave in lead 3, look at your P wave in V1. It's inverted, but it's very spiky. See how spiky it is in lead 2 and spiky it is in lead 3? Spiky and inverted here, okay? So first I say, oh, that P wave doesn't look quite right. I'm kind of concerned about that P wave. That P wave, that shape, that visualization, the height of that P wave is telling me about distribution of electrical current through an enlarged right atria. And then I'm going to look at axis, and I'm going to tell you this is almost a non-defined axis because I wouldn't say from a quick look that it was significantly a right axis, but I am going to say that I have a big R wave in V1, a big R wave in V2, and a big R wave in V3. So I'm now saying something is wrong. This is not a normal EKG. I'm pretty comfortable saying this is pulmonary hypertension along with a right bundle branch block. I don't have a right axis deviation. I have something else, and that would be a left anterior fascicular block. You're not going to do that. All you're going to do is say, this doesn't look good to me. And along with the symptoms, we're going to ask for further investigation. And the further investigation is going to be an echocardiogram. Okay, so going to do a pulmonary function test, looking at lung disease. That might be a cause. Does the patient have OSA? We're going to actually evaluate them as they walk to actually help us qualify what their class is. Typically, if it has not been diagnosed after an echocardiogram, which gives you a guesstimate of your PA systolic pressure, you're going to get a right heart catheterization. Okay. Now I can put a PA catheter in you in the unit. You know, 15 or 18 years ago, we would just drop a PA catheter in the ICU. We'd document the pressures and take the catheter out. Didn't have to go to the cath lab for that. In today's world now, because people are not very used to using PA catheters, it's just safer and better to go to the cath lab where they put catheters in all the time and they're under fluoro. So they're not doing it blind like you're doing it in the unit. You're doing it blind, looking at the waveforms with people that don't know how to look at the waveforms because we don't do PA catheters much anymore. So it's not safe. Now we send patients down to the cath lab and we do a right heart catheterization there. Put the PA catheter in, document the pressures, take it back out. You don't need to keep it in once you've documented the presence of pulmonary hypertension. So echocardiogram first, cardiac cath, right heart cath second. Okay. So all those things, chest x-ray, echo, pulmonary function test, lung CT, and a right heart cath. If you actually have true pulmonary hypertension, not nosocomial, which we cause by our method of ventilation, there is no cure for this. Everything is symptom relief unless you get a lung transplant. Okay. So it's all about symptom relief. And it's really important to remember that with significant pulmonary hypertension, you're going to have severe, profound right heart failure. When you have right heart failure, what happens to the right ventricle? It dilates. What happens to the right atria? It dilates. What happens to your veins? They dilate. Where is all your volume? In your veins. Okay. And in your veins, you're going to engorge your liver. You're going to have ascites. If I press on your liver for 20 seconds, your neck vein will distend. Now, that's important for you to know. That's called the hepatojugular reflex. Press on the liver for 20 seconds, the neck veins acutely distend. Positive hepatojugular reflex is indicative of right heart failure. Right heart failure occurs in our generalized practice from a pulmonary embolism, from pulmonary hypertension, from RV infarct, and from volume overload, those four things. Positive hepatojugular reflex designates that I have right heart failure. I've got so much venostasis of veno volume, press on the liver, neck veins distend, positive hepatojugular reflex, and we're going to use that to help us to understand right heart failure. Okay, so depending on the patient, depending on their symptoms and their failure to oxygenate and their right heart failure and their limitation, we're going to consider putting them on pulmonary vasodilation. Okay, now there's a lot of different pulmonary vasodilators. Okay, the most common ones that we see, that we talk about, are Velitri and Flolan, which are phosphodiesterase inhibitors, Flolan and Velitri. We also look at nitric oxide, which is directly vasodilating and actually is an agonist of prostacyclin. If I had my choice, I would always go to nitric oxide, but it's more expensive. So typically we use Velitri or Flolan. Now, the Velitri and Flolan are delivered via the endotracheal tube. Nitric oxide is delivered via the endotracheal tube. So these are acute settings of therapies that we provide to patients. Long-term, patients can have an indwelling prostaglandin E1 pump, or they can take oral phosphodiesterase inhibitor, which is Viagra. Won't be called that. Viagra is a phosphodiesterase inhibitor. It's going to be called sildenafil. Sildenafil is Viagra, and it promotes arterial dilation. Be placed on sildenafil, Viagra, do is symptom manage their disorder. Patients with severe chronic pulmonary hypertension, by the way, my friends, they're going to need a lung transplant. Everything else is symptom management. Okay. So done with that component. Going to review something we talked about before. And what I'm reviewing that we talked about before is the points of wisdom to remember that whenever we're looking at lung function, we're going to differentiate hypoxia from hypercarbia. Oftentimes you see the both together. Sometimes you see hypoxia, but not hypercarbia. Sometimes you see hypercarbia, but not hypoxia. And that's going to be really important because that's going to help us define what it is that we want to do with and for our patients in terms of support. whether support is just pure oxygen, whether it's CPAP, BiPAP, intubation, and mechanical ventilation. And we're going to need to be very fluid with that. And we're going to utilize our APG to help us determine what it is that our patient needs and what we're going to do with support, with ventilation support or breathing support related to the blood gas and to whether this is hypoxic or hypercarbic. So I want to remind you about blood gas. Remember, you look at the pH to tell you about the direction of your problem. Any pH that is less than perfect, 7.4, is on the acid side. Any pH that is above 7.4 is on the alkaline side. If it's inside range, which is 7.35 to 7.45, it means that you either just have a natural normal variation or you have a variation with compensation. Your pH only deviates from perfect because there's some variation. You've got to figure out what the variation is. Is the variation acute? Do you have compensation? So first I'm going to look at the pH and I'm going to say, is it up? Is it down? Is it inside range or outside range? Then I'm going to look at CO2 to see, is CO2 the cause of the pH alteration? CO2 goes up, more acid. CO2 goes down, less acid. I'm going to look at the bicarbon, the base, to look at whether metabolics are the cause or the compensator. And I want to remind you, don't really look at bicarbon base. Just remember that when bicarb base go down, metabolic acid is up. Okay, carbon dioxide up, respiratory acid. Bicarbon base down, that means metabolic acid, which is hydrogen, is up. CO2 is up, hydrogen is up. You have dual acid. So it's really helpful for us to remember that. And then we look at the PO2, we look at the O2 sat, and we think about the PF ratio. Now, I'm going to define what's wrong with my patient, and I'm going to make decisions about oxygenation, and I'm going to make decisions about carbon dioxide. I want you to remember that in order to remove carbon dioxide, your alveoli must recoil. So we distend them when we take a breath, and then they recoil and exhale the breath out. Recoil takes time. Recoil takes normal alveolar parenchyma. So we know that if you have chronic obstructive pulmonary disease, you have destruction of the normal alveolar parenchyma and you lose recoil. You're distended, you can't recoil. You can't empty the air. In CO2, it's the recoil and the time allotted for exhalation that matters. So your lung must recoil and it must have time to actually exhale. So those are two really important things. When my patient is retaining CO2, so CO2 is above 45 and the pH is down from perfect, they have a primary respiratory acidosis. The first thing I'm going to think about is what is their respiratory rate and what is their tidal volume? Because these two things are going to affect CO2 mobilization. So I want you to really separate this here. When I'm looking at management of hypercarbia, I'm going to look at respiratory rate and tidal volume. Respiratory rate times tidal volume equals minute ventilation. Normal minute ventilation is 8 to 10 liters per minute. And on your ventilator, that's designated as V subset capital E. V with a dot over it, subset capital E, that's minute ventilation. That's the real deal. That's the amount of volume that you exhale per minute, and it's measured as respiratory rate times tidal volume. Now, I want to remind you that in the old days, we'd intubate somebody, we'd start off at 500 mils tidal volume per breath. We don't do that anymore. We start much lower, and we ultimately look at setting our ventilation support, our tidal volume support at 6 to 8 mLs per kg. Aha, you said, we don't weigh our patients. Our beds are broken. We put patients on broken beds all the time. We don't really worry about the weight. We don't measure them even when our beds work because we're too busy. Weight is really important, but actually not here. I don't really care about your weight because the size of your thoracic cage is determined by your height and by your gender. So when we talk about predicted body weight in ventilation, predicted body weight is achieved by looking at a chart that says, if you're a man who is 5'8", the tidal volume for 6 mLs per kg or 8 mLs per kg is 380 or 410. We're going to use a chart. That chart is known as the ARDS-NET PBW chart. ARDS-NET, all one word, ARDS-NET, one word, space, PBW chart. That's what your respiratory therapist uses. That's what your physicians and APPs should be using. We are not actually looking at your weight. We're looking at your gender and your height, which determines your thoracic cavity size. So we use the ARDS-NET predicted body weight chart. You can look it up on your phone. It's really easy. You can validate that. You can always know how we should be breathing our patient. Okay. The reason we use 6 to 8 mLs per kg is because we have discovered that in our past, in our attempt to ventilate and oxygenate patients effectively, we were overdistending the alveoli. And as we overdistended the alveoli, that caused an inflammatory injury that could lead to ARDS, ventilator-induced ARDS. We no longer overdistend our alveoli. So we start initially with the idea of 6 to 8 mLs per kg. Well, this is an emergency. We've intubated you. We're typically going to go somewhere between 375 and 4 or 425 until we can look up the chart and adjust your tidal volume. It used to be 500, but not anymore. Okay, because we do not want to overdistend your alveoli because that causes profound damage to the alveolar parenchyma. Yes. Recruitment maneuvers are different. And that's fantastic. And thank you for asking a question. We will get to that. Okay. Recruitment maneuver is about popping open closed alveoli. We're not talking about that. We're just talking about when we're just doing standard ventilation, you have to protect the alveoli that are open. You cannot over volumize them. I don't know that that's a real word, but I don't want to over distend them. Okay. Okay. All right. So I want to just remind you again about CO2. This is a really important concept for us to remember, that when we talk about CO2, we talk about CO2 in 3 ways. The product of tissue respiration, cellular metabolism, that's why it's called a respiratory acid, not because you manage it with your lungs, but because it is a byproduct of tissue respiration. I'm going to measure how much CO2 you've made. I measure that in the venous bed. So I'm going to do a partial pressure of venous CO2. That tells me about CO2 production. That CO2 is continuously transported into the lungs, where if I have good alveolar recoil, I'm going to blow that CO2 out. As long as I have good blood flow past the alveoli and good alveolar recoil, I'm going to blow that out. That's your end tidal CO2. That's what's eliminated during exhalation. So that CO2 that was produced is transported to the lungs in the bloodstream and it's diffused across the cellular membrane at the alveoli. And what I'm looking at is your end tidal CO2. In order for your end tidal CO2 to be effective, you must have alveolar recoil and you must have blood flow past the alveoli. So when I have a pulmonary embolism, my end tidal CO2 is going to go down because I don't have blood flow past my alveoli. I've got an embolism. That makes sense? Okay. What remains after production and elimination is what's in the artery. So I've used this visual forever. I'm very happy with it. I designed it. I think it's very expressive. Number 1, produce carbon dioxide measured in the veins. Number 2, eliminated carbon dioxide, end tidal CO2. And 3, in the arterial bed, what remained? I produced it, I eliminated it, and here's what remains. Now, if I'm producing a lot of CO2, I'm going to expect my patient to breathe fast and deep to get rid of it. Does that make sense? CO2 is an acid. I've made a lot of CO2. I've got good blood flow through the lung. I'm expecting the patient to breathe fast and deep and move that CO2. So my purpose here is not to teach end-tidal CO2, although you may have some questions about it. And it is a very, very informative when we talk about end-tidal CO2. What I want you to remember is that end-tidal CO2 should always go in the same direction as arterial CO2. End-tidal CO2 is measured by the amount of carbon dioxide that's being removed over the time that it's being removed. It's what we call a volumetric measure. When I am hypoventilating, it takes a long time for CO2 to be cleared. And that's why with hypoventilation, your CO2 goes up. With hyperventilation, you're breathing fast, you're clearing less CO2 per breath, but over a minute's period of time, you're clearing a lot of CO2 because you're breathing fast. So your end-tidal CO2 goes down. Okay? Normal values. The only one you need to remember, and it's the one you should always know, is arterial. Arterial CO2 is 35 to 45 millimeters of mercury. Everybody knows that. That's probably embedded in your brain. Add 5 on either side, meaning 40 to 50 is your normal venous CO2. Subtract 5 from either side, that's your end-tidal CO2. If arterial CO2 goes up, I expect that end-tidal CO2 goes up. If arterial CO2 is down, I expect end-tidal CO2 to go down. If my arterial CO2 is high and my end-tidal CO2 is low, that's a perfusion problem, and it's an indicator for pulmonary embolism because I'm not flowing blood past my alveoli. I'm not clearing the CO2. My end-tidal CO2 is low, but my arterial CO2 is high. Now, that's really important from my point of view because the response is, I see that your arterial CO2 is high. I try to correct that with the ventilator. But if your end-tidal CO2 is low and your arterial CO2 is high, I need to correct that with blood flow. Good? You feel good about what I've just said? Okay, because I think that's a really important thing. Okay, I'm going to say it here and I'll say it again. Okay, so normal end-tidal CO2 is 5 less than arterial CO2 on either side. I always expect that my end-tidal CO2 is going to go in the same direction as arterial CO2. If I am hypoventilated, I'm going to be clearing CO2 over a longer period of time, which means the absolute measure goes up when you're hypoventilated. You think if I'm hypoventilated, I should see end-tidal CO2 goes down. That's not correct. When I'm hypoventilated, end-tidal CO2 goes up, arterial CO2 goes up. That's hypoventilation. If I'm hyperventilating, arterial CO2 goes down, end-tidal CO2 goes down. So when I'm trying to make this match with ventilation, okay, hypoventilation, CO2 is up in the artery and in end-tidal. In hyperventilation, CO2 is down in end-tidal and arterial because they should always travel in the same direction. Here's the thing. When they are not traveling in the same direction, arterial and end-tidal, that is typically a perfusion problem. And it's so important for you to appreciate. So when I'm hypoperfused, my end-tidal CO2 goes down, but my arterial CO2 is up. That is never normal. Never, ever, ever normal. End-tidal should always go in the same direction as arterial CO2. So if my end-tidal CO2 is down and my PA CO2 is up, my very first question is, does this patient have a pulmonary embolism? Does he have an alteration in blood flow? I'm not clearing the CO2 because my blood flow past my alveoli is ineffective. Does that make sense? 99% of the people who monitor end-tidal CO2 at the bedside only think about it as it relates to ventilation, except for one thing. When you do CPR, what end-tidal CO2 are you trying to achieve? In your ACLS guidelines, effective CPR means that you are clearing CO2 at a level of 15 or above. Whenever that number drops below 15, you need to change, or you need to get your Lucas. We all think we're the greatest CPR deliverers in the world. But if we look at, because we're like, oh, look, I'm shaking the bed, I'm breaking the ribs, things are great. I look up at that end-tidal CO2 and it's 8, things are not great. Need a change. I would tell you, always get your Lucas, always get your Lucas. But if you can't do that, if you know ECC, ICU, rapid response, it's a mechanical compressor. Always at depth, always at rate, and typically with an end-tidal CO2 clearance of greater than 15, usually greater than 18. So you start your CPR, you're looking at end-tidal CO2, look, it's at 18, fantastic. 30 seconds later, up, it's at 15. 30 seconds later, it's at 12. Okay, you've only been doing CPR for a minute and a half, it's time for you to change. For whatever reason, people have so much pride about their CPR, they won't change when they're tired, they're sweating all over the bed, they're not doing good CPR. I'm okay, I don't need a relief. Well, everybody wants to do the right thing for the patient, and you've done a great job, but it's time for you to get off. Right? If I'm in your room, I have often said, time for a change. And I have people turn to me and say, nope, I'm not tired. And then I say, you're not clearing CO2, it's time for a change. Okay, so that's your end-tidal CO2. Okay, so let's see what we know here. Okay, so PV CO2 is 45. Is that normal? Yes or no? Venous CO2 is 5 plus on either side. Is the PV CO2 of 45 normal? Yes or no? Yes. Go over here. PA CO2 is 40. Is that normal? And end-tidal CO2 is 35. Are these normal? This is great. Exactly right. Now we're going to look at this patient. PV CO2 is 59. Is that normal? That's high. Okay, so you're producing a lot of CO2. I'm going to expect, if you're producing a lot of CO2, that you're going to clear a lot of CO2. Your end-tidal CO2 is 26, but actually let's go over to PA CO2. Your PA CO2 is 50. Is that normal or is that high? That's high. Now, right away, when your docs see that PA CO2 of 50, they're going to say, let's increase the tidal volume or the respiratory rate and clear more CO2. But look at your end-tidal CO2. Your end-tidal CO2 is 26. You have poor perfusion. Change in the ventilator and go make that patient better. You need to enhance their perfusion. PV CO2, arterial CO2 up, end-tidal CO2 down. That should never be. This is bad, and this is a perfusion issue. Yes?
In this instance, where it's poor perfusion and increasing the ventilator actually cause more perfusion.
Yes, it can, and it usually does. If we have that August 3rd class, if you help me remember, I'm going to give you the case of TS. TS was a woman who had a pulmonary embolism in, at that time, the MICU on 7K. And she was our very first hospice patient. And we moved her from 7K to 5J. She had a terrible pulmonary embolism and everybody was treating it with the ventilator. And I kept saying, look at the numbers here. Your patient has a pulmonary embolism, but they kept going up on PEEP and they kept increasing the tidal volume and the respiratory rate, and it got worse and worse and worse. She was not going to survive. They didn't make that worse. They just didn't make it better. And she was the reason I remember her so well, first of all, because I talk about her a lot. I have a fabulous case study on her, but also because she was our very first hospice patient. So we moved her from 7K to 5J. And when she went down to 5J, and I had been with her working with the ventilation and the team and the medical ICU team for days on her. And then the first time I met Dr. DeSandre, and then we moved her down to 5, and the family's decision was to extubate her, and they were going to give her analgesia and sedation. And the bedside nurse, I totally respect that, said, I'm not going to do that because I think it's going to facilitate the end of her life, and I'm not going to participate. So I looked at Paula and I said, well, I'm here. I'll do it. Yeah, a long time ago, Rachel was at that bedside with TS, who she lived with her girlfriend, and the girlfriend and the family had different points of view. Yep. I can't believe that. I can't even believe you remember that. Fantastic. Yes, we proned her. She was our first prone in the MICU as well. Exactly right. I have pictures of her in the prone position. So, no, this is more than that, isn't it? Oh, well, then it was 10 years ago. If you were there, it was 10 years ago. Wow, it seems like longer than that. I was thinking it was 20, but I wasn't even here 20 years ago. So it wouldn't have been 20 years ago. And that was the first time you met me. And I know that you were very happy to understand that extubation was going to give her a better death. So, okay. So anyway, down memory lane. Okay. Now let's look at this one. PvCO2 67. So that's high. PaCO2 is 55. So that's high. And tidal CO2 is 50. That's also high. But end tidal and PaCO2 moved in the same direction. So this is a ventilation problem. I need to blow off more CO2. So the arterial CO2 goes down and the end tidal CO2 goes down. The more CO2 I blow off, the more my end tidal will go down unless I don't have blood flow. Okay. Okay. How about these ABGs? Courtesy of Mallory. Mallory gave me, the assignment was after pulmonary 1 was everybody had to do 10 blood gases and turn them in. So Mallory did them. Rose did them. Nobody else came to class that week, and nobody else gave me their blood gas. It's okay. So, but I wanted actually the blood gases to already have been diagnosed, because the purpose isn't for me to get blood gases. Purpose is for you to diagnose the blood gas. So here's your patient's PO2, 140. Here's the patient's arterial stat, 0.98. I don't have the FiO2, so I can't do a P to F ratio. Just for your understanding, it's never enough to get PO2 and SaO2. I have to have FiO2 because that tells me about your gas exchange and tells me what I need to focus on. Okay, patient's PaCO2. Well, let's start with the pH. pH, 7.51, perfect up or down? Up, inside, outside range. So do you have a problem? Yes, and that problem is alkaline. CO2 is 40, perfect up or down? That's no, perfect up or down. Perfect. So no variation there. This is not the problem, nor is it compensating. Go over here. Your base is 7.2. That means your bicarb is around 33. So base is up and bicarb is up, which means metabolic acid is down. Metabolic acid down, pH is up. What's your problem? Metabolic alkalosis. In order to compensate, you'd almost have to stop breathing. Your patient would have to be breathing much more slowly and accumulating CO2 to get that pH down. Okay, so this is what we would call acute metabolic alkalosis, probably from overdiuresis. I don't know anything about the patient. Okay, PO2 74, sat 0.94. pH, let's go over to pH. pH, perfect? Yes or no? No, not perfect. Up or down? Up, inside or outside range? Inside range. Okay, good. Okay. So you're on the alkaline side, but you're inside range. That could be either a normal variation or an abnormality with compensation. Now go to CO2. Am I retaining or exhaling? No, this is PaCO2. Am I retaining or exhaling? Retaining. I'm retaining acid, but my pH is on the alkaline side, so this cannot be the problem. PaCO2 is being held in the blood to try to bring the pH back down because my base is 5.6, my bicarb is 30, base and bicarb up, metabolic acid down. This is chronic metabolic alkalosis. The word chronic means compensated. Mallory, are you good? Okay. You take this one. I think these are all kind of the same patient, but maybe not. Okay. All right. So we see this patient is actually hypoxemia, right? We know they're hypoxemia, so we need to deal with that, but we don't have their FiO2, so we're not sure what the problem is. We'll look over here at their pH. pH is perfect. Yes or no? Up or down? Inside, outside range. So that inside, 7.35 to 7.45. So you're inside range, but you're down, which means either this is just normal variation or you have an abnormality with compensation. Go over here, PaCO2. PaCO2 is up, which means you're retaining carbon dioxide. You're not exhaling, right? It's in the arterial blood, correct? So if this is the cause of your problem, your pH should go down. Is this the cause of your problem? CO2 up, that's acid up. pH down on the acid side, is this your problem? Yes, this is respiratory acidosis. But your pH is in the range of normal, and it's in the range of normal because your base and bicarb are up and your metabolic acid is down. This is chronic respiratory acidosis, compensated respiratory acidosis. Everybody good? Yes? I was going to have Mallory do that one, and then I didn't. Okay, so this is kind of the same thing here. Let's move down to this one. Okay, so Mallory, can't really know much about the oxygenation because I don't know what FiO2 you're on. Never, 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 and you know, I didn't ask you for it, never, ever report a blood gas without talking about FiO2. Because otherwise, I could be on 100% or I could be on 30%. If I'm on 30% FiO2 and my PO2 is 150, I've got good lungs. If I've got 150 PO2, but I'm on 100% FiO2, my lungs are terrible. The more oxygen required to make you oxygenated, the worse your lungs are. Okay. So I always need to know what your FiO2 is. So in your clinical practice, never report without FiO2. Okay. All right. So start with the pH. Perfect. No. Up or down? Okay. It's down, but inside range, which means either normal variation or abnormality with compensation. That's always how you know what's happening. Go over here and look at CO2. Perfect, up or down? Inside, outside range. Okay, so I'm blowing off acid. I'm not retaining that acid. I got rid of it. CO2 is down. Is that the cause of your problem? No. Is my problem with my pH on the acid side or the alkaline side? Acid side. Am I retaining carbon dioxide, which is an acid, or am I blowing it off? So it cannot cause my pH to go down. Go over here. Your base is negative 8.2. Your bicarb is 16. Base and bicarb are down, so metabolic acid is, you can't see the metabolic acid, memorize this, Mallory. Bicarb and base go down, metabolic acid is always up. Metabolic acid is up and the pH is down. The cause of the problem is, okay, are you compensating? Because your pH is in the range of normal. How did you compensate? You increased your respiratory rate. and you blew off CO2. There's only so much room in the blood for the metabolic acid hydrogen and the respiratory acid carbon dioxide. If metabolic acid hydrogen goes up, I must get rid of CO2 to maintain a functional pH. Everybody good? Okay, so that's kind of the highlights of that. We'll be doing more blood gases later. Now, as we think about mechanical ventilation, we're going to think about a couple of properties. We're going to think about your tidal volume, the amount of volume you move in and out of the lung to remove CO2. And we're going to think about functional residual capacity, the amount of air that stays in the lung that keeps your alveoli open. Tidal volume, the amount of gas you're moving in and out of the lung with each breath. Functional residual capacity, the amount of air that stays in your lung, keeping your alveoli open. Tidal volume and respiratory rate. Tidal volume and respiratory rate are about carbon dioxide. Period. End of discussion. Tidal volume and respiratory rate are driven by presence or absence of CO2. Functional residual capacity, we're going to treat that at the bedside. Now I'm going to say something that's not going to be that meaningful to you, and then I'm going to translate it for your exam. Functional residual capacity is always driven by a mean airway pressure. For you, you're going to translate that into PEEP. PEEP or CPAP or EPAP. PEEP, CPAP, EPAP are about keeping air in the lung, increasing functional residual capacity. That is about oxygen. PEEP, EPAP, CPAP increase functional residual capacity, air that stays in the lung. Air that stays in the lung keeps your alveoli open, prevents them from collapsing, recruits them. I'm not recruiting you with the tidal volume. I don't recruit your lungs with tidal volume. I recruit your lungs with PEEP. If I'm going to do a lung recruitment maneuver, I'm using PEEP. I'm not using tidal volume. I'm using PEEP. Half the lung is collapsed because you have ARDS, not collapsed like we talk about in pneumothorax, but alveoli are not open. I'm going to drive your PEEP up until I've opened your alveoli. That's it. Functional residual capacity, PEEP, CPAP, EPAP. There are other things. We use pressure control inverse ratio, APRV. No one's going to ask you that. That's more intimate than you really have to understand. What you have to understand is if my patient has alveoli that are not functional, I have to increase functional residual capacity. And I'm going to do that generally with PEEP, EPAP, CPAP. And I'm going to use FiO2. So let me just make sure you understand this. Most important thing you have to understand about ventilation, tidal volume and respiratory rate are manipulated to address CO2. Functional residual capacity, manipulated by PEEP, CPAP, EPAP, plus FiO2 are about oxygenation. So in the most straightforward way, even if I don't say anything else about mechanical ventilation, when my patient is retaining CO2, I'm going to address that with tidal volume respiratory rate. And if my patient is hypoxemic, I'm going to address that with FiO2. Mean airway pressure strategies, which increase functional residual capacity. And in general, that will be PEEP, let me say it another way, CPAP first, EPAP second, and then intubation and application of PEEP. CPAP, EPAP, PEEP. So in your own mind, you've got to divide these things. That makes it really relatively easy to say, if you have primary hypoxia, your PO2 is low, but your PaCO2 is fine, I'm not putting you on BiPAP. You don't need BiPAP. You need CPAP. You need FiO2 and you need CPAP. Pardon me? You can always increase your FiO2, yes. FiO2 first, CPAP next. Okay. If I'm hypercapnic and just hypercapnic, that means my CO2 is elevated, but my oxygen is acceptable. You need tidal volume. The first step in tidal volume is I can ask you to breathe deeply, but that probably isn't going to work. I'm going to put you on BiPAP. BiPAP, IPAP, inspiratory pressure, IPAP on BiPAP determines your tidal volume. Your tidal volume helps you clear CO2. So I'm going to set your IPAP to increase your tidal volume and clear your CO2. That doesn't work, I'm going to intubate you. And I'm going to use respiratory rate and tidal volume to help you clear CO2. Okay. Now, these are other types of respiratory failure. You can't protect your airway, you're using too many muscle groups. But for us, we're just really talking about setting oxygen, CPAP, EPAP, PEEP to oxygenate patient, FiO2, CPAP, EPAP, PEEP for oxygenation. For hypercapnia, IPAP, pressure support, tidal volume, and respiratory rate for CO2.
Hey, Barbara.
Yes.
Hey, I got a question for you. So in my experience, I find that
Just, would you do me a big favor? Could you speak just a bit louder and a little bit more slowly?
Okay. This is Derek. In my experience, I found that the people that are hypoxic, that are awake and talking to us before we experience any mental status changes, frequently are the air trappers, and they are not tolerant of CPAP in and of itself. So I found that BiPAP works better because it allows them time to exhale. The CPAP doesn't allow them time to exhale, and so then we will wind up going to some other high constant pressure, high flow delivery device, maybe a nasal cannula, high flow nasal cannula.
So you're mixing a lot of things up here. So let me just do this little part, and then I'm going to address what you've said.
Sure.
Okay. So for oxygenation, you're going to look at FiO2 and whatever form of distending pressure. So depending on what you're using, CPAP, EPAP, PEEP. Okay. For ventilation, which is the removal of carbon dioxide, you're using respiratory rate, tidal volume, and ultimately minute ventilation. Okay, respiratory rate times tidal volume. Okay, so Derek asked a question. He goes, I found that putting patients on CPAP who are air trappers. Well, if you're an air trapper, your problem is not really oxygenation. Your problem is CO2. If you're trapping air, that air is dirty. That's CO2 rich air. When you trap air, you need a methodology that helps you clear your gas. CPAP will not help you clear your gas. You have plenty of time to exhale on CPAP. You just have a continuous pressure. Well, PEEP is a continuous pressure, my friends. It doesn't just get applied at the end of exhalation. It's a continuous pressure. If your patient is air trapping, they are going to be CO2 retainers. CO2 retainers are not helped by the delivery of oxygen. CO2 retainers are helped by tidal volume and respiratory rate. When I do BiPAP, I don't control your time for exhalation. The only way I can control time for exhalation is to intubate you and deliver gas in really fast. And that's way beyond what we need to talk about here. But you've mixed up a lot of metaphors, and that was fantastic, but you're not separating it correctly. If your patient is an air trapper, he's a CO2 retainer. If he's a CO2 retainer, oxygen is not the support for him. He needs BiPAP or intubation. Patients who retain CO2 do not get oxygen therapy. They get exhalation therapy. Exhalation therapy will be tidal volume and respiratory rate, and only if you are controlling their ventilation, which you are not doing with BiPAP. You're supporting it, but you're not controlling it. You can set a rate, but they can breathe all they like. The only way I can control this is with intubation and changing how fast I'm putting the gas into the lung, which then affects how long the patient has for exhalation. But I can't really do that with BiPAP. Okay, so I want to answer the question, but I also want to recognize sometimes, because I love that Derek is so knowledgeable about ventilation and really trying to do the right thing, but I also don't want to get us kind of into the weeds. But I'm very happy for you to come to an advanced ventilation class where we will totally be in the weeds and where we're going to go and look at people who are on ventilators. But for our purposes here, we're going to talk about FiO2 and distending pressure. Distending pressure for us will be CPAP, EPAP, PEEP. Okay. The only difference between CPAP and BiPAP, or CPAP and ventilation, is that I support the inspiratory side. CPAP is just a constant pressure, but when you give somebody PEEP, it's a constant pressure. When you give somebody EPAP, it's a constant pressure. Constant pressure intermittently interrupted by the delivery of a breath. That's the only difference. So whenever you want to oxygenate your patient, you're going to have to use a constant pressure to keep the alveoli open. If you need to remove CO2 as well, they must get intermittent tidal volume. I've never said it that way. That seems so straightforward to me. Pardon me? Can you speak up? BiPAP. Typically, patients who are air trapping, yes, thank you so much. Typically, people who air trap are the ones whose alveoli cannot recoil. They've lost their elastic property. That is COPD, correct. It also could be overdistension of the alveoli by the way I'm breathing for you, but pathophysiologically, it's the COPD patient. Instead of 16 alveoli on the end of a respiratory bronchiole, and all those alveoli distend, recoil, oxygenate, CO2 removal, oxygenate, CO2 removal, oxygenate, CO2 removal. They just distend their alveoli. And because they don't remove CO2, CO2 takes up all the space in the alveoli. And that makes the CO2 in the blood go up because you can't move the CO2 out of the blood because you're not moving it out of the alveoli. Those individuals, they need tidal volume, respiratory rate, and to Derek's point, time for exhalation. So if you put them on a respiratory rate of 30 with the tidal volume of 6 mLs per kg, but you're not addressing the time for exhalation, they're not going to have enough time to exhale. And that's what he was talking about, but that's a concept beyond the CCRN exam. It is a concept at the bedside that we have to understand. Because, by the way, very few people actually look at that when they're talking about ventilatory management of patients, and they're all over, why is the patient's CO2 up? We've given him a minute ventilation of 13, normal is 8 to 10. Well, yes, but you're not giving him time to exhale. Time to exhale helps you to remove CO2. Again, a little bit beyond where we are here. Okay, my friends, 4 major issues in ventilation. I'm going to stop. Is your patient oxygenating? Okay, for oxygenation, FiO2 first, CPAP, EPAP with BiPAP, or PEEP. That's what affects oxygenation. Is your patient removing CO2? IPAP on your BiPAP, tidal volume, respiratory rate, and time for exhalation. IPAP and BiPAP is the difference between the continuous pressure and the intermittent pressure. So the difference between those two, IPAP minus CPAP determines your tidal volume. You need more tidal volume to remove your CO2. Good? Are their lungs compliant? You know that based on the amount of pressure that is generated when you are delivering gas. So best way to measure this is to look at their inspiratory pressure, peak inspiratory pressure, and the pressure that is generated when I trap gas in your lung. That's called P plateau. So we've talked about that before. Okay, inspiratory pressure should be less than 40. P plateau pressure should be less than 25. If my lungs are non-compliant, the worst pressure is the P plateau. And P plateau pressure is going to be higher than 25, typically higher than 30. Your lungs are not compliant. If your lungs are not compliant, your alveoli are not distended. How am I going to distend your alveoli? CPAP, EPAP, PEEP. In whatever strategic way I'm going to use it. CPAP, EPAP, PEEP. To open your lung. And of course, ultimately, you're going to look at how are they working to breathe. The harder they work to breathe, the more consumption of blood flow and oxygen at the diaphragm, and it's going to steal it from the heart, and it's going to steal it from the brain, which is why their mental status changes, which is why you start to see dysrhythmia, because the diaphragm and the accessory muscles are working really hard. You're not going to do that under my care. I don't want you to work hard. So I'm going to look at your blood gas and say, what's your problem? Is your problem oxygenation? Is your problem CO2 removal? Is it both? If it's both, I'm not giving you CPAP. You're going right away to BiPAP or right away to intubation because I've got to support CO2 clearance, which I'm going to do with IPAP or tidal volume respiratory rate with the ventilator and time to exhale. And if it's oxygen, I'm going to address that with FiO2 and EPAP with BiPAP or PEEP on the ventilator. All you have to really appreciate is I'm going to address oxygenation with FiO2 and distending pressure. PEEP, EPAP, CPAP. Cool? If you need to remove CO2, the primary way I'm going to help you with that is tidal volume and respiratory rate. And to Derek's point, an excellent point, I need to assure that you have time for exhalation. So I need to be sure that you're not breathing so fast that you don't have time to exhale. Okay? So it's 5 minutes after 10. We started around 3 minutes after 8. So I'm going to end here. We're going to have many more talks about ventilation. We're going to talk more about ventilation. You know, that's why I have that extra day at the end. And also talking about shock. We'll have a lot of things that we can put together in shock. I'm going to make an announcement here. I'm going to send it out to you. I leave on Saturday for Israel. I'm speaking at the International Cardiology Conference. This is like my 7th time. So I've been to Israel about 10 times, but I've spoken at the cardiology conference 7 times. And then I speak at hospitals all up and down Israel. I spend a lot of time there. Please say a little prayer for me, just because there's lots of rockets going off there right now. And I spend a lot of time in bomb shelters. I've done it before. I'll do it again, no problem. But I will be gone for the next 2 weeks. So that's why I did pulmonary today. Originally, I was supposed to do it next week. Kathy Peavy will be doing the next 2 sessions, and she will be doing them virtual only. Because July 5th, she's still out of town, and July 12th, she's not able to do it in person. So for the 5th and the 12th, it will be virtual only. Kathy Peavy will be running that. And then we will return to the ECC classroom. Today is our last Steiner Auditorium day, because next week, new residents are here, and they've got to be tutored in the Steiner Auditorium. So just want to be sure everybody knows that for the next 2 weeks, virtual only, and then we'll come back together. We'll have ethics, we'll have shock, we'll have everything else that we need to review or that we didn't get to on that last day. That'll be in August. And then I hope, my friends, you are going to feel really comfortable taking your CCRN or your PCCN exam. Thank you, Derek. Safe travels, he says. And by the way, August 27th, God willing, I am also going to the Ukraine, where I'm going to be teaching fundamentals in critical care support, surgical and ICU liberation to 300 trauma surgeons in Lviv, which is on the west side of the Ukraine, and up to now has been relatively safe, but they've had 2 drone attacks. So you might see me those 2 weeks because that trip may get canceled. I'm not canceling, but the Society of Critical Care Medicine is who's taking me there. So I've got 2 really big trips. I'll have lots of interesting things to tell you. And I will be spreading the word of how great Grady is everywhere in the world that I go. I always spread the word about how great Grady is. And thank you guys so very much for being here today, for studying, for trying to expand our knowledge together. A special thank you to Derek Allen, who has been in lots of classes and is always striving for excellence and is always comfortable speaking out. I love that. I adore you. Thank you guys very much. I'll see you in 2 weeks, or this afternoon if you get on virtual talk. Okay, bye. Thank you.
Thank you, Barbara.
Thank you. Bye-bye.
It's Rose.
I know. Love you, Rose. Bye.
Love you too.